I'm going to talk about the perfect fit starts with a perfect pick. So what is the decision making that we should do in Aphakia? So we know that primary implantation of the IUL in the capsular bag is the standard of care. But there are occasions when this does not happen and when even implantation of an IUL does not happen. So these are all complications, capsular complications, which are the most common among the intraoperative complications, where you are left with very inadequate capsular support. Or when we have other associated complications like a poor visibility because of a long duration surgery, or we are unsure of the outcomes, like we do not know what lies beneath, like in a phagomorphic or phagolytic glaucoma, non-availability of the required IOL. So we have planned it is a negative lens or it is a very low power lens, and we do not have a three-piece variant of that in that model, and we may have to postpone the placement of IOL. When the surgeon has inadequate experience to place the IOL, as a primary surgeon is not sure if he can really place the IOL, and again, a doubtful visual prognosis. So a secondary IOL, after ascertaining the improvement in visual acuity, would be in place, like in traumatic cataracts. So you don't know how much the damage is. So you may choose to do the cataract extraction first and then the IOL placement. So the preliminary workup is pretty much like the scheduled one, but still it has got to be more thorough. You have to do an Aphakic correction, including the astigmatic correction. The best corrected visual acuity has to be measured. The slit lamp examination needs to be done. The posterior segment examination needs to be thorough. Do a biometry, routine investigations, and special investigations. So why an Aphakic correction with astigmatic correction? Because that's what is going to give you the correct, best corrected visual acuity, number one. And number two, it also indicates the amount of astigmatism, and if you can take some measures to correct it, then you can do so. This also indicates where you can place your prospective wound for your secondary IOL. So let us say that if it's a lot against the rule, you can choose to do a temporal tunnel for your secondary IOL. Again, the best corrected visual acuity, because we would like to do secondary IOLs, preferably those who are getting better outcomes. So arbitrarily, we can set the standard as better than 612. And also remember that we need to meet the patient's expectations. So when he is coming to us, he wants a good vision and he expects more out of that surgery. But post-operatively, always remember that the vision may improve, or it may remain the same, or it can even deteriorate. So we cannot promise the vision, and especially when it is lower, we definitely cannot. But having said that, we cannot be very strict about this standard, because especially in young patients who have undergone cataract extraction following traumatic cataracts. So they will not be able to tolerate the anisometropia caused by aphakia in one eye and a normal eye and the normal vision in the other eye. So in these cases, even if it is improving to say 624 or 636, they would appreciate it if we could place a secondary IOL. So one of the mandatory things, especially in a setup like Aravind, where there are multiple people examining and examining and measuring the eye and all that, the slit lamp examination should be done by the operating surgeon, and he should pay attention to certain conditions. In conjunctiva, especially the position of the scar, where has been the previous wound, whether sutures are present now, whether you would like to remove those sutures, whether there is vitreous incarceration in the wound, in the cornea, the presence of scars, any difference in the size like a micro or a megalocornea, because then your IOL is going to be more of an iris claw. In the anterior chamber, quiescence. So it is usually preferable to take at least after 1 month, because there can be a flaring up of inflammation, preferably after 3 months when everything has settled down. The depth of the anterior chamber, irregular or shallow, the presence of vitreous in the anterior chamber. The iris, studying the iris is very important. The texture of the iris should neither be too thick nor thin, shaft, or atrophic. and also look at the continuity. So whenever you want to do an iris fixation, you need iris 180 degrees apart. And this actually comes into play, especially in post-traumatic cataracts and secondary IOLs, where a lot of iridectomy may have been done. The pupil should preferably be mobile. So when you are seeing a case, you really do not know. So you should see it primarily without any dilatation, and then after dilatation. Now, if you can see that the pupil can be 3 mm and can also be 7 mm, then that is, that gives you a lot of relief, because there you can judge what lens you can keep, and you can go ahead with any type of IOL. But if you've got a fixed dilated pupil, like with the traumatic mydriasis, then you may have to think only about sterile fixation and not about iris claw. Status of the posterior capsule should also be checked, because at the time of surgery, one may have felt that the IOL would not stay stable. But now, after the fibrosis of whatever remnants are there of the anterior capsular zim and of the posterior capsule, it is possible that you may just be able to place a three-piece in the sulcus, which I believe is second best to a capsular back placement. The posterior pole examination should be done with a 90D, especially paying attention to the macula and the optic disc. In indirect ophthalmoscopy, it depends on we have to check for the media clarity. So there can be a seeping of blood into the vitreous, like you saw in some of these cases. And peripheral retinal lesions, which need to be treated, and time given before you plan your secondary IOL. Residual lens matter, which is possible. And always do an IOL to rule out a dropped IOL. Now, we had one case where we went ahead and put in an AC IOL too. Those were the days, about 10, 15 years back. And then this patient used to constantly come to us in the OP. And he says, I'm all fine. But when I shake my head like this and look like this, and then he used to draw exactly the foot plate of the oroflex IOL. I see this image. So the only thing that we could tell him was, please don't do that. Okay. So always. So another thing is, like, if it does get into some litigation or something, more liable than the person who dropped it is the person who put an IOL without looking at that drop. Okay. Routine investigation assumes more importance when planning secondary IOL. The routine investigations, especially are intraocular pressure and aphakia, is usually complicated with glaucoma, and you have to decide what you're going to do, whether you're going to treat medically before and after, or you're going to do some additional surgery. Madam is going to talk about infection control in secondary IOLs, and we should know that as a secondary procedure, secondary intraocular lenses carries a very big risk, a 6 to 10 times more risk of endophthalmitis, in spite of all precautions. And therefore, the establishment of the nasolacrimal duct patency is extremely important. Coming to biometry, preferably optical biometry, because now, except for central corneal opacities, the media is clear. IOL calculation formula can be done with the SRKT for actual lens above 22, Aphakia below 21, especially because you do not have the other additional measurements required by Barrett, like the lens thickness. You should pay attention to the keratometry readings for planning the incision if you want to correct the astigmatism, and the IOL power according to the planned IOL, whether it's an SF IOL with a more posterior placement. There may be a difference between a retina person placing it and an anti-segment person placing it, or correct is constant of the iris claw IOL. In cases with corneal opacity where you may not get proper K readings, you'll have to then consider whether you're going to take the other eye K readings or whether you're going to take the standard K of 44, 45. Constantly monitor the outcomes of these cases, every type of IOL for every surgeon, so that you know that when you're doing this and this particular type and this particular IOL, then you need to adjust your IOL power calculator accordingly. In the special investigations, specular microscopy holds a special place, because There is loss of endothelium due to a traumatic primary surgery. There is loss of endothelium consistently thereafter because of contact with vitreous. And now your secondary IOL is going to reduce your count further by another 10-20%. And so for this, we have got to remember that we have to measure the endothelial cell count. And I have put a very, very strict figure of 1,800, but I think below 1,500, you're going to lose more. The macular OCT is helpful in assessing the status of the macula. So you know, because these are likely to get repeated attacks of cystoid macular edema and subsequent degeneration. So you can do an OCT macula to find out what is the prospective vision. So the choices that are available to us are the three-piece IOL in sulcus, either the PMMA or foldable acrylic, the iris fixated IOL, the iris claw or iris fixation with sutures. The slide fixated IOL, we have got the sutured SFIOL, and now the flanged SFIOL and intrascleral haptic fixation by various techniques like Chariot and Yamane and XNet. Now, there are other factors, ocular factors, which are influencing the choice. They are the previous wound and scar, so you plan whether it is superior temporal or sacrotemporal. And according to that, the more convenient ones, like an iris claw or a flanged IOL. Then on the status of cornea and visibility, if the visibility is very low, I believe a flanged IOL would work much better. With sutures, it will work much better because much of the work that you're doing is outside the eye. Whereas if you are going for an intrascleral haptic fixation, much of it is going to be like the traditional Chariot's way, then much of it you will have to do it in the vitreous cavity, which will not be very visible. Again, you have to look at such a disorganized anterior segment where a wide iridectomy has been done. There's a lot of scarring, and 180 degrees of iris is not available for a proper iris fixation. Again, very thick iris or floppy iris or with iridotomies all over, again, may not be ideal conditions for iris fixation, and SFIOL may be preferable. A large dilated pupil, traumatic mydriasis, we have to go for an SFIOL. Naturally, iris fixation is not possible. A non-dilating small pupil, iris claw is much better, or iris suture IOL is much better, and a partial PCM, a single haptic fixation to iris may be enough if you can rest one of the haptics in the sulcus. So all these will decide what will be your type of IOL. Apart from these, there are certain general principles which need to guide you for choosing your IOL. The surgeon's skill and comfort. Now, I would request all surgeons, whoever go into secondary IOLs, to be proficient at least in 2 techniques, or at least knowledgeable of 2 techniques. Because on table you take one and something happens, you will have to immediately shift to the other. You have got to do some thinking on your feet, unlike most of the cataract surgeries. Keep the 2 styles of IOL ready and 2 powers each, spare power also, so that you don't have a secondary IOL placement after planning a secondary IOL surgery. You have to give him an IOL. And so make sure that you have got the proper powers of whatever IOL you're going to put. It may be the same or a little plus or minus, but you have to have the IOLs. Ensure that all other supplies are available, like the requisite Prolene sutures, 10O or 9O, straight and short curved needle for a suture SFIOL. Prolene 10O, 9O with 2 long curved needles for iris fixation of haptics and for pupil repair. Many times you may have to take up pupil repair, which I think will be shown by Jevint or Navneet. Prolene 70 on special needle and low heat cautery as shown for flanged IOLs. Specialized Clayman forceps, or you also have some arms which you hold at the center, will show you where to enclave the iris claw. Microforceps used in PPV, straight and curved for the Chariot's technique, and the XNet as we saw, and the XNet for the SFIOL XNet technique. So to sum up, secondary IOL implantation, first of all, needs a proper planning, a thorough anterior segment examination by the surgeon himself, ensure the potential for good vision, and yet give a guarded visual prognosis to the patient. A thorough anterior segment findings need to be noted for related to choosing the IOL. Ensure proficiency in at least 2 techniques. Ensure adequate supplies and availability of IOL, 2 models, 2 spare IOLs, and all the possible sutures. And finally, choose the appropriate IOL as per the eye, as per the proficiency in the technique, and an uneventful post-operative course. So whichever behaves good in your hands, which has the least stormy post-operative course, that should be the one selected. Thank you very much.